So a few things to just sort of know about epinephrine before we move into what the protocol is. And there are a ton of different protocols. I've come across protocols that have multiple times the dose of what I'm recommending here. But this, I would say, this is the one I've come across the most. But anyway, so epinephrine. So it's a good drug, right? It can increase the contractility of the heart, it can increase heart rate, it can peripherally vasoconstrict, so you're shunting blood towards the core of the body to improve your hemodynamics. Now let's think about how the drug comes, right? So there's two concentrations that we see epinephrine in. You have the 1 to 1,000. What's that one for?
Allergic reaction.
Allergic reactions, right. Historically, it was used also for increasing doses of epi, but that's no longer done. Good evidence to say that, if 1 milligram didn't work, 10 milligrams isn't going to work, right? So we're not doing that. That's historic. So now the only reason to use it is really allergic reactions. So 1 to 10,000 is what we usually call code dose or cardiac epi, right? What does that actually mean? There's 1 gram in 10,000 mLs, which is 1 gram in 10 liters, right? So 1 to 1,000 is 1 gram in 1 liter, okay? So what we have in our code dose epi is a roughly 10 ml syringe, right? And that has 1 milligram in it, okay? So you have a 1 milligram, 10 ml syringe. If you get rid of 9 mLs of that stuff, and there's a number of ways to do this, but in general, how we're going to do that, we're going to waste 9 mLs, we're going to draw up 9 more mLs of normal saline. So what have you done to the concentration? You went from 1 milligram in 10 milliliters to what now? Yeah, exactly. You went to 0.1 milligrams, 100 micrograms per 10 mLs. Does that make sense? Okay. So the other thing I want us to think about epinephrine is how let's just say they were started on a drip already. So a typical starting rate for a drip is 0.05 micrograms per kilogram per minute, okay? So you're looking at an average person, let's just, for ease of math, we'll say they're 100 kilograms, right? So if it's 0.05 micrograms per kilogram per minute, you're looking at a typical starting dose on a drip of about 5 micrograms per minute. Does that make sense? Okay. So when we look at our protocol up here, which calls for anywhere from 5 to 20 micrograms per dose, which is 0.5 mLs to 2 mLs of that solution that we have made, that's a pretty low dose, right? And on the flip side of this, if you going for an interfacility transport and you see somebody who's on an epi drip and you're like, wow, that is a super high dose of epi, you're looking at kind of the high end. There is technically no maximum dose a physician can order for epi, but a pretty high dose would be 50 micrograms per minute. Okay? So just giving you that kind of range. It's about 5 micrograms to 50 micrograms per minute. Okay? So we're on the lower end of that spectrum, right? So if you do kind of the bigger dose, which is 20 micrograms, you're still a lot lower than it would be if it was an infusion at its max rate. Okay? But the thing you got to keep in mind is people's bodies adjust to drugs. This is the first time they're getting a pressor, right? So their response should be more robust than it would be if they've been on this drug for several hours and they're just not responding as well as they need to. Okay, and part of that is because these drugs rely on the body's reserve, and that's important to think about. If one of us has an IV in place, and you push 5 micrograms of epinephrine, that response is way different than that person we pick up from the nursing facility who's kind of barely hanging in there. Does that make sense? Because their reserves are diminished, their adrenal response is going to be diminished, their vasomotor response may be diminished. There's lots of reasons why people just don't respond the same way. Otherwise, there wouldn't be a range, right? I would tell you to use a dose and it's going to work, but everyone's different, right? And when you have pre-hospital providers at our level here, we should be able to adjust to the circumstances so we have that range available. So then, how this simulation went was awesome, but would have been slightly better to say, okay, during our timeout, so we have Mr. Blank, we're going to intubate for airway protection and oxygenation. We're going to use succinylcholine for paralytic and ketamine for our sedation. Will you do further sedation with ketamine? But I also anticipate, right, because one of the things we talk about with airway during our timeout is anticipated complications or challenges, right? And I anticipate the blood pressure is going to get lower, so let's give a push dose of epi now, okay? You have that push dose ready to go, right? Even if you're not going to give it, you have it ready to go. That's the other step, right? I'm not going to give it, but I have the push dose epi in my front pocket, ready to provide if we get lower. And I would say something like that if the pressure's say 95 to 100, right? We're not quite committed to wanting to increase that, but once you start getting in the 80s and you're gonna do an intubation, especially deep into the 80s or 70s, like was the situation here, it really is gonna help you to just give a little dose beforehand. And I would view this almost like pre-oxygenation, right? You are trying to optimize that patient's parameters for successful intubation. How do we define a successful intubation? Is that purely just getting an ET tube in place? No, right? Because would you have been better to just bag that patient but not make them severely hypotensive for 10 minutes, right? So it's the whole package, right? Successful intubation is, getting an effective airway in place, oxygenating, avoiding hypoxia, avoiding hypercarbia, avoiding hypotension. That's a successful intubation. I don't even necessarily say a successful procedure requires the actual intubation. If you abort the tube and put in a supraglottic device, but they didn't get hypoxic, they didn't get hypercarbic, they didn't get hypotensive, I would take that any day over the ET tube with hypoxia, hypotension, and all that other stuff. Does that make sense? So, and this is, nationally, this is more on the radar for quality control of intubations. Really, historically, it's like, well, did you get the tube? Okay, and then the second question would be like, how many attempts, right? But now it's not just that. It's like, okay, you got the ET tube, that's awesome. First pass success, that's great. But how are our hemodynamic parameters? How is the oxygenation during that procedure? Okay. So we're already awesome, right? But we're trying to take our awesomeness to the next level, so we're going to try to really pay attention to those parameters. Push dose epi is another tool we have available to help us be able to do that, optimize those parameters. And this is just one of multiple examples where push dose epi can be helpful for us. It doesn't have to be pre-intubation. You might just have the person who's severely hypotensive, they're maybe already intubated, or any number of reasons this is reasonable, okay? Because there are options. I've started dirty epi drips and things like this, but that's different scenarios. This is just easy, and it does have a pretty decent effect. Now, important to think about, this is kind of extra credit, but does anyone know what the half-life of epinephrine intravenously is?
5 minutes.
What's that?
5 minutes.
You're really close. That's a really good guess. And honestly, that might even be right in some people, but it's about 2 to 3 minutes. Okay. And so you consider that, what does that mean? So your effectiveness of that drug is going to be about half within about 2 to 3 minutes, or the bioavailability. So you're going to have some effect usually for 5 to 10 minutes. Okay? So you have to expect that you give that push dose of epi, 5 to 10 minutes later you need to be reassessing. But we're doing that anyways, right? Because typically our cuff is going to be going off every 5 minutes or so. We're going to be seeing that. So yeah, that's a really good guess. But yeah, about 2 to 3-ish minutes. IM, it lasts a little bit longer, just because it causes vasoconstriction, uptake's a little bit lower, things like that. But for IV push dose epi, you're going to get about, in general, 5 to 10 minutes of effect. Okay, and but that's perfect for us, right? Because we have relatively short transports, right? And taking the time to make a drip just doesn't usually make sense, right? And if we're doing an interfacility transport and the person's blood pressure's already soft before we leave, we're going to be thinking into the future like, gosh, this is a potential pitfall for us. Let's have a presser in drip form available, ready to go, right? All right. Are there any questions about this at all? And this is, so there are, like I said, other protocols for this, and this one I just came up with not that long ago, so there may be some ways to make it better. But that said, look it over, try to get comfortable with it. If you have feedback for me on it, questions, anything like that, just let me know. Okay. Are there any questions about push dose epi?